Hello everyone, I'm Dr. Monica. Today's video will be on cohort study. So let's begin with the topic. Now the word cohort has military roots and it originates from a Latin word cohorts, which means a group of soldiers. It is a non-experimental or observational study design. Coming to the definition part, it means a group of people with defined characteristics who are followed up to determine incidence of or mortality from some specific disease or causes of death or some other outcome. So, a cohort is a group of individuals who share common characteristics, for example, age, occupation, or any specific health condition. And this group, it will be observed for over a period of time to monitor who will develop the particular disease, who will die from the disease, or any kind of other health outcomes. So, observational studies, these are research methods where no intervention is made, that is, no treatment is done, and researchers simply observe what happens. So, it has two types: analytical study and descriptive study. In analytical, the researcher tries to find out why a disease happens, and in descriptive, the researcher just describes what is happening. So the descriptive study, it is further divided into cross-sectional, cohort, and case control study. Cross-sectional studies, they look at people at one moment in time. And coming to case control study, it compares people with a disease to people without it. And coming to cohort study, which is longitudinal, it follows a group of people over time to see who gets a disease. So for the cohort study, we can say that we begin with exposure and follow for disease incidence. So coming to cohort study design, so let's first understand what is a cohort. From the source population, we select people who do not yet have the disease to be studied and who can be followed up over time. So let's understand this design with the example of whether smoking leads to lung cancer or not. So here we start with source population, that is with a large group of people, and we choose cohort from the source population who have defined characteristics and who can be followed up over time. So we ask the cohort how many packs of cigarettes they smoke per week. Talking about choice or happenstance, here some people in the group might smoke, that is they are exposed, and some might not smoke, that is they are non-exposed. So we follow up both the groups, that is exposed and non-exposed, for over years to see what happens. So outcome in each group might be some people might develop lung cancer, which is an event, and some might not develop lung cancer, that is no event. So we compare the both the groups and results, and check how many smokers have got lung cancer versus how many non-smokers have got the lung cancer. So in a cohort study, a group without the disease is followed over time based on exposure. Because exposure is recorded before the disease occurs, these studies can help us show the cause and effect. Also, they have a potential to provide the strongest scientific evidence to the available literature. So cohort studies, they can be prospective or retrospective, and prospective studies, they follow people from present into the future, and main disadvantage is that it needs a long follow-up time. Coming to retrospective cohort studies, so they look back at existing data, and they are faster and they are less expensive. Retrospective cohort studies, also called as historical cohort studies, they look back at past medical records to study the outcomes. So they are faster to conduct, less expensive because the data already exist. The only disadvantage is that the researchers can't control how well the data was collected. So talking about selecting the study cohort, so firstly define the source population clearly. Choose the study cohort by applying inclusion and exclusion criteria. ensure participants are free of the outcome being studied at the start. So, talking about the selection of subjects in cohort studies, the subjects are chosen based on their exposure status at the start of the study. So, both exposed and non-exposed groups, they come from the same source population. So, people already at risk for the outcome, they are excluded from the study. The source population, it is chosen by sampling. Subjects, they may come from hospital, communities, or private clinics. So next is attrition bias, that is loss to follow-up. So it happens in long follow-up periods, especially in prospective cohort studies. So this occurs when the researchers, they lose contact with the participants, causing the missing data. Too much loss weakens the study's validity, and ideally loss to follow-up should be less than 20% of participants. Talking about defining a drug exposure groups. So define two or more exposure groups, including a control or reference group, and the reference group should be clinically relevant. So follow-up must be properly categorized to avoid biases, and exposure definitions must match the study's hypothesis. So exposed group include people who are exposed to the risk factor being studied, whereas the control group include people who are not exposed to that risk factor. So sources of exposure information can be obtained from medical or other records, interviews, questionnaires, physical examinations or lab tests, environmental measurements, or daily activity logs. So outcome information in a cohort study can be collected from various sources such as death certificates, hospital or physician records, disease registries, self-reports from participants, and direct physical examinations or tests. So coming to measuring occurrence of outcomes, to ensure valid results in a cohort study, outcomes must be measured accurately. So if the outcomes are subjective like diagnosing pneumonia, assessors should be blinded to exposure status to avoid bias. When using the existing data, validated outcome definitions from past studies should be used. So a variable is considered a confounder if it is linked to both the exposure and the outcome, but is not on the causal pathway. To reduce the confounding in cohort studies, matching is done between the exposed and unexposed group based on these variables. So the common biases seen in cohort studies include exposure misclassification bias. In this, there is incorrect categorization of subjects' exposure status. Next is change in exposure level over time. Participants' exposure may vary, affecting the study accuracy. Next is loss to follow-up. Missing data due to subjects dropping out from the study. Non-participation bias. So this occurs when those who choose not to participate, they differ systematically from those who do intend to participate. Last one is the reporting bias. This is inaccurate information given by the participants during the study. So coming to relative risk, it compares the risk of a disease in an exposed group to the risk in an unexposed group, where A is exposed with disease, B is exposed without disease, C is unexposed with diseased, and D is unexposed without disease. And it is calculated by incidence of disease in exposed group by incidence of disease in unexposed group. So how do we interpret relative risk? RR equal to 1 means no difference in risk. RR greater than 1 means higher risk with exposure, and RR less than 1 means lower risk with exposure. So coming to the advantages of cohort studies, it provides detailed exposure data with good quality control. Clarify the time between exposure and disease, allows study of multiple outcomes from one exposure, It enables us to calculate incidence and relative risk. Also useful for studying rare exposures. Also easy for non-epidemiologists to understand methodology and results. They are also ethically safe, and baseline matching of subjects are possible and can determine the timing of events. Also, standardized criteria for eligibility and exposure or outcome assessment is provided. So, talking about the disadvantages, they are not good for rare diseases due to large sample size needs, and also long time between exposure and the disease can be challenging. Changes in exposure patterns may affect the results and difficult to maintain high follow-up rates. Other disadvantages include expensive due to large sample size requirement. Baseline data may be limited because of large numbers. Exposure might be linked to hidden confounder, difficult to implement blinding, and no randomization involved. If you have liked the content, please like, share, and subscribe.